Good afternoon. Welcome everybody to this meeting of the Derby and Derbyshire Integrated Care Partnership. I'm Councillor Alison Martin and I'm chairing this meeting as the co-chair of the Integrated Care Partnership. My other co-chair is Councillor Carol Hart from Derbyshire. So do we have any apologies for today?
Yes, we do. We have Tracy Allen, Avia Bartia, Carol Camis, Gino Di Stefano, whose rep is Bell Hobbs, Mary Dooley, Karen Hansen, Councillor Natalie Hoy, William Legg, Mark Powell, Stephen Posey, and Simon Stevens.
Thank you very much, Lindsay.
Chair, could I just add one? Councillor Natalie Hoy just had to call off at the last minute. Sorry.
Thank you. And just to say, if you're not aware, if you wish to speak, you need to press on the microphone in front of you and then turn it off when you don't want to speak. And obviously not Carol, but...
Could I just add one? Councillor Natalie Hoy just had to call off at the last minute.
When you speak the first time, if you wouldn't mind saying your name for my benefit, please, and which organisation you're from, because obviously I don't know you all, but I know many of you, but not all of you. So thank you very much. We don't have any late items. Any declarations of interest? No? I've no doubt you've all read through the minutes of the last meeting. Are we all happy to confirm those minutes as an accurate record of the meeting? Carol, thank you, Carol.
Happy to propose.
Everybody else happy with that? Thank you. Any matters arising from those minutes that anybody would like to raise now that they don't feel they'd be able to raise later on in the agenda? No? Okay, thanks very much. Well, in a slight digression from the agenda, as set out before you, I'm just going to start the meeting with a context-setting update, if you like, from an update from the Chief Exec of the Integrated Care Board, Chris Clayton. Thank you, Chris.
Thank you, Chair, and thanks for pulling this item forward. I suppose it sets the context of one of the stakeholder partners, really. So for those that don't know me, Chris Clayton, Chief Exec of NHS Derby and Derbyshire. So you should have the report in your pack. The aim of this is just to bring some context to the Integrated Care Partnership of what's going on through integration in the NHS. So I recognise it's quite detailed and broad, but it covers quite a few material areas. So it starts by setting out the work that we are doing in the NHS to bring what we call the NHS family together, so colleagues recognise that the NHS is a broad organisation with lots of different partners in it. So a key role of the ICB, the Integrated Care Board, is to support that integration across the partnership. It's also to work with other partners, and hence why we're an important stakeholder and partner here. In terms of what we're trying to do, and there's a couple of paragraphs in there that describe this, we are trying to balance, I think in the same way we all are, managing today and managing tomorrow at the same time. And so there's reference in the report to an important conversation we had in October about trying to understand the joint forward plan that the NHS has put together, the 5-year plan. It's been here before, but also to try and put some context to that about what we're doing in year 1, year 2, and so on, and how do we start to change our approach, which we all want to do in terms of getting more upstream. So hopefully you'll see that update, and thanks to those colleagues that supported us in that conversation. The report goes on as well to describe some of the key other works that the NHS is going through. It would be remiss of me not to say we are in what it feels like to most of us winter now, and so we're all challenged by activity and demand on our key frontline services, and particularly, we welcome the support that we have from both councils on social care and domiciliary care and the work that we're doing in partnership around that. And also, you know, we want to be key contributors to the items that are on the agenda later about, you know, the Stay Well agenda. We're committed to it. So hopefully colleagues appreciate that. We reference, it's interesting, I hope you spotted this, but we reference in our work as an NHS the important contribution of the combined authority, and we recognise the work that both upper tier councils have done in that regard. We see that from an NHS perspective as an important contributor to improving health through the socio-economic development that will occur through that. So it's important, hopefully you see that we, even though it's distant to the working of the NHS itself, we see it as an important contributor. And we're trying to work across the NHS on two key integration approaches. So I've mentioned it before, the provider collaboration. So I've mentioned we've got lots of different providers in the NHS. How do we bring those together to work on the pathways of care? But also, hopefully, colleagues will recognise that we will be putting a lot more emphasis on our working places. And of course, we've got city and county, and within county, we've got lots of sub-place groupings that we feel are important to our strategy. And it's probably all I'd set out. There's lots in there around virtual wards and so on. We've talked about those in other meetings like the Health and Wellbeing Board, but I'll probably take questions there, Chair, if it's all right.
Of course, yes. Like just before I bring in questions, I'd just like to say a few quick points myself. I'd like to congratulate Michelle Arrowsmith on her appointment as the Deputy Chief Exec of the ICB. I have met Michelle, a very impressive woman. So it'd be good to work with her going forward. I'd also like to congratulate NHS Derby and Derbyshire on having made significant progress in its first 9 months, according to NHS England. So in its annual assessment. So that seems very positive to me. So anybody else would like to come in and ask questions of Chris? Carol first, Carol Hart.
Right, Carol Hart, Cabinet Member of Derbyshire County Council and Co-Chair of the ICP. You know, you mentioned, Chris, in your report about a combined authority. I mean, when that first was mooted, health was just not envisaged to be involved in it all, and I think that it's taken a lot of talking and persuasion that now I think health is up there with other areas, but I think it was concerning that health was left out. So I think we just need to make sure that, you know, that we make sure that we get our message at the table, because as I say, it seemed a last minute thought, which is totally wrong as far as I'm concerned. You know, so that was just really an observation. Thank you, Chair.
Julie, did you want to come in?
Thank you. Councillor Julie Patton. I'm Cabinet Member for Children and Families at Derbyshire County Council. Chris, could I just ask you where we are with CAM's waiting list, because it's quite an issue at the moment. Just wondering where we're at. Thank you.
Yeah, I mean, I haven't got the absolute number for you at the moment, and obviously we can send that through, but I think we all recognise, don't we, that CAM's waiting times is a challenge to all of us, and you've got within that different cohorts. At the very severe end of the spectrum, we've got waiting times with regards to admission and hospital placements, but also you've got in the lower tiers of care challenges in terms of general CAMS waiting lists. So happy to bring something back or update colleagues with more specific details around the current waiting times, but I recognise the question, certainly.
Thank you, Chris. I assume you can share that information with Julie outside the meeting, and then, if appropriate, include that in your next update to the ICP when we meet in a couple of months' time. Any other comments or questions for Chris? No? Well, thank you very much for your update. I have read it. It is quite comprehensive. Thank you very much. So now we're going to move on to our sort of main topic, if you like, today, where we look at the second key area of focus, which is the Stay Well focus. And Jane Needham is going to present this. Jane, perhaps you could say, for the benefit of anybody watching, what your role is, please. Thanks.
Thank you, Councillor Martin. So my name's Jane Needham. I'm the Director of Strategy, Partnerships and Population Health at Derbyshire Community Services. But I'm here in my role as SRO for Population Health Management for the system. Thanks very much. This gives us the opportunity to provide an update on the progress that we've been making on the Stay Well key area focus of the integrated care strategy. I particularly just want to thank colleagues in the room from the two local authorities, from the ICB and from all of the providers in the system, because we really have been working alongside each other on this particular area of focus. So what I was intended to do was to just rattle through, taking it that the paper is read, with regard to why this area of focus has chosen the priority areas that we've settled on, and then to bring everyone up to speed on the approach that we're taking, how we hope it will be, that will provide learning for the system for a range of different integration pieces of work, and also to just highlight around some of the barriers that we're looking to unblock in order to make us move forward more quickly on this. So that was my intention. So if I just cover straight off in terms of what is the Stay Well key area focus. So it's one of the 3 key areas of focus of the integrated care partnership strategy. And the priority area that was settled upon and agreed probably back in January now was to improve, that the focus is to improve the prevention and early intervention of the 3 main clinical causes of ill health and early death in our population. So that's circulatory disease, respiratory disease and cancer. And just to provide some context, they account for 2 out of 3 of every early deaths amongst our population, and they also account for 50% of the gap in inequalities between our most affluent and our least affluent areas. So there is a strong rationale as to why we chose those areas. So in terms of trying to make sure that we got shared ownership around this, there is a Population Health Management Steering Group which was established just over a year ago, and which was asked to take the leadership for this particular area of focus back in January, February time. And the approach that we've taken is very much to focus on the integration and to recognise that we're not starting from scratch with this key area of focus. There's already really good work going on, but we haven't cracked it. I think we would all agree that we are not doing as well as the potential around these areas. So it seems sensible to make sure that we worked an integrated approach to recognise the different skills and assets that come from different parts of the system in it. So those 3 clinical areas cause a massive burden of ill health in our population, and to make this manageable, what we decided to do was to take what we call a driver diagram approach. So we focused upon the key drivers of those 3 clinical conditions, and when we think about what those 3 key drivers are, they are rooted in social determinants of health and health behaviours. And when we took that driver diagram approach, which I think is part of the paper, what it was apparent is that smoking is an area that is still the single biggest preventable cause of ill health, and which crosses across all of those 3 disease conditions. So it was agreed that we would focus on smoking cessation because of the benefits against those 3 clinical conditions, and also because it is one of the areas that actually touches into any number of parts of the system. So I know that we've got voluntary sector colleagues sitting at the back here. Voluntary sector partners are really important in this as well, and we recognise that sitting into providers and sitting into the local authority, we've all got the opportunity to influence smoking cessation. So our intention, because we wanted to recognise the work that's already going on, and for each of our elements that we want to drive forward on this key area of focus, we wanted to develop an approach that had a sprint, so a really focused, targeted piece of work that people put a lot of effort into, with an exit strategy, so that we can then move on to look at other areas of focus and other drivers that would support our key area of focus. So what we were aware of is there's a lot of good work going on around smoking. There is an intention at the system level to set up a tobacco control group that is being chaired by Ellie, my colleague at the front, Director of Public Health for the county. So there was a really clear route of, if we could put a sprint approach into smoking with a really close connection to the people who would be continuing with the tobacco control group, it would help that longevity and that sustainability of this as a driver. What we also wanted to do is to make sure that we focused on the health inequalities around this particular area. So what we do know is that from the data that's been that we've had available to us as part of this piece of work, is that there's currently 140,000 people across joined up care Derbyshire who are registered as smokers. What we also know is that smoking is one of those risk behaviours that tends to be underreported, because not everybody will is willing to enter into a conversation with their doctor that they are a smoker, so there's potential underreporting of that. And so in terms of where we could focus on health inequalities, we wanted to start looking at some of the data that told us where the inequity occurs around those 140,000. And it's not going to come as any surprise to the people in the room, but we can look at some of the factors where we have poor outcomes. So, for example, smoking at time of delivery for pregnant mums is higher within our area. When we start to really dive deeply into the data, what we find is that people who are living in social housing are far more likely to be smokers. People with severe and enduring mental illness are far more likely to be smokers. So this gives us the ability to target particular groups and to really ensure that the resources that we have got, we are supporting it towards those people who most need our help. So the other approach that we want, or the other kind of way of working that we really wanted to bed into our key area of focus throughout, is to recognise that there is really strong evidence base around the work that we want to do. And we already do work across the system. And if there are pockets where we have got evidence-based interventions around any part of cancer, circulatory disease or respiratory disease, we need to challenge thinking that if it's not working in that area, it's because it's not evidence-based. Actually, it's evidence-based. If it's not working in our area, what we want to do is to lean in and to understand why. For example, we know that local authority provided smoking cessation services are 4 times more likely to help you to quit than trying to quit alone. So if we're not getting adequate throughput through those services, what is it about our access criteria and what is it about the referral routes from people who are coming into contact with smokers that means that we're not getting that throughput? So we really want to make sure that the evidence-based interventions that we've got are maximised and optimised as far as possible. And then I've already kind of touched upon this sprint approach, and it's really interesting because we are now at the start of our sprint. We've timed it for smoking so that it encompasses the January quit, when a lot of people set quit dates themselves. And we have had a timeout session, which has really allowed us to look at, if we're going to take a strategic approach to this, what are the 3 main areas that we need to focus upon? And I would suggest that this is probably the same for quite a number of the drivers that we will then take forward. So we have looked at the sprint approach through 3 lenses. The first is the lens of a strategy, so really making sure that we've got a strategy that will transition through into the tobacco control group, and that membership of the tobacco control group are involved in setting those strategic aims so that there is that continuity. Second is around the comms, so to make sure that we've got really great communications around population approaches to smoking cessation, so those key messages that go out to the whole of the population around the benefits of quitting and the benefits of not starting in the first place. And then also targeted approaches that will connect in with our individual communities where we know we've got high prevalence rates. And then the third area is the delivery group. So this is around really ensuring that we tie up the people who are involved in the delivery in its broadest sense of evidence-based interventions, in this case to reduce smoking. So in there we've got the providers of all the main organisations, we've got the 2 local authorities who deliver the evidence-based services, and we've got the voluntary sector because they touch in so much with people who are smokers. And the sprint approach, we settled on the sprint approach because at the moment, as is the case, I do think for all of the key areas of focus, people are putting effort into this in addition to their day job. So we haven't got it resourced through separate means. So just asking people to really lean in and for a dedicated period of time give maximum focus to it. What we heard back from our partners is that gives us a sense of purpose. We know what we can achieve in that short period of time, and we're prepared to really put that effort into it. And it's an approach that's used in industry, and which when we connected in with the evidence, we found that was likely to be successful. So we've gone for this sprint approach. And in terms of the evaluation of this, when we come to the end of our sprint approach, what we're looking to evaluate is what have we achieved in terms of moving forward at a faster pace, strategic direction and delivery around smoking cessation. But really importantly, does working in a sprint approach foster integration? Does it make it feel more manageable? And what's the experience been like for partners in keeping pace with that sprint? So I think that's going to be something that will be quite interesting, and we've factored in a lessons learned approach at the end of this particular sprint. And then the other thing that we wanted to do, and it's sort of towards the end of the report, is to just focus in on the areas that, as we are now, a couple of months into the development of and a couple of weeks into the sprint approach, is to flag up to the Integrated Care Partnership today some of the things that we are wanting to unlock as part of our work, which we hope will then unlock issues for other integrated work that we want to do. And as people will be really aware, we are coming up against issues around information governance and issues around using data for population health management purposes in the way that many of us have talked about it over a number of years. And so what we are looking to do is to support using a Section 251 application process and taking it down to its, what does that mean? What it means is an application process to the health, which is based on our knowledge that there is data contained within our health and social care systems that will allow us to proactively engage with people to improve their health. It might not have been collected originally for that purpose. So the 251 agreement, if we get that through, will mean that we then have the authority to utilise that data to support proactive management of people's health. So what we are not going to do is put that through just for smoking cessation. We're working really closely with colleagues to put that through as an application for population health management purposes for Derby, for Joined Up Care Derbyshire, so that whatever we want to do from a population health management point of view, hopefully that 251 application, if approved, will allow us to do that. And then a couple of other issues just in that last paragraph of the report is around the issues that we are beginning to unpick around trying to work in an integrated approach quickly. Key area is that voluntary sector partners, we are really struggling to enable them access to basic channels such as Teams to share documentation, to share information, to share meeting invites because of the permissions that are set up in the background. We've managed to kind of crack it for local authority colleagues, we've managed to sort it for NHS colleagues, but we're not managing to completely achieve it for the voluntary sector, and they're such an important partner that, again, if we really lean into that, we hope that if we crack it for this Stay Well agenda, it will support other system working. And then I think there is just that last point around a reflection of, I'm going to phrase it carefully, is people are really leaning into this, and I am hugely appreciative of the support that I'm getting in this role. I'm also very, very conscious that people are doing this on top of their day jobs, and actually I would challenge us as a system that if we are really setting a direction around prevention, which the Stay Well key area focus is absolutely rooted in, the recognition of being able to deliver against such a massive agenda in addition to your day job is limiting the pace at which we can move it forward. And that is, you know, notwithstanding, with great respect, I understand the position that we are all in as system leaders. So I'm hoping that that's given a good background to where we're at. If there's any questions at all, happy to try and answer them. And I've also got really good colleagues who I can also pull on if there's anything I'm unable to be able to answer myself. Thank you.
Thank you, Jane. That was really helpful. I mean, I think there are two things here, aren't there? There's the whole issue of smoking cessation, and there's the way that illustrates the case of how we can try and fulfil this integrated care agenda as an integrated care partnership, and what that might mean, and how that. And I think right from the start, resource is always going to has always been and would always have been an issue. And in fact, I did my first intervention in this role was to add the issue of resource into the introduction to the integrated care strategy. Now, the thing is, there's no point, attributing blame here as such, because everybody's resource is low and everybody is stretched and everybody has, strong responsibilities to their organisation, don't they? Already dealing with pressures there. So I thank you and the team for what you've done on this work so far. And eventually, in some way, we do need to address that issue of resource. I noticed when I read the minutes of the last meeting that was also raised, that there isn't anybody to kind of steer and lead the work. And whilst people can work together in a quasi-voluntary way and share ideas, and at the point when it becomes more systematic and more professional is when you've got somebody who's designated to drive it. So I think that is a concern for integrated care systems across the piece. I'm going to shut up in a minute and let somebody else come in, but I did go to the Integrated Care Systems Leadership Conference along with Chris Clayton in London, and then last week, the week before, and then after that I went on to the Adults and Health Conference in Bournemouth, and I did talk to other cabinet members there. I won't name the counties where locally they had created sort of directors whose responsibilities were, say, adult social care and integration, and they were warning me against that simply because of the level of difficulties we're facing at the moment in local government. They felt that, you know, the focus had to be on trying to deal with the, you know, the current crisis, if you like, as Chris was saying earlier on. It's the immediate and the future. Trying to deal with those simultaneously is really difficult. So I can really appreciate the work you've done. I'm sure everybody in the room probably knows far better than I how difficult it is. And yet we do have this strategy, and we are tasked by the system to try and do more strategic integrated working. So I would like to come back in a bit to those more strategic points and some of the barriers you raise, and also item 2.3, the items, consider the items for escalation. But would anybody else like to make comments at this stage? Chris Clayton, thank you.
Thank you, Chair, and thanks, Jane. I really appreciate it. So really welcome this single priority area, and I couldn't, you know, welcome it more in terms of its alignment. It's helpful that it aligns nationally with the national ambition. So really welcome it. A couple of technical questions, really. So recognising the sprint approach and the methodology, but recognising this is also a marathon to improve this, and having those two things in our mind. So my understanding is the sprint helps us to create the action plan, which we then implement. So we want to see that back here. The question in my mind is this an aligned objective across both the ICP partnership and the Health and Wellbeing Board partnership? I've not seen the Stay Well in that, so it would be helpful if it is, because then we tap into a broader partnership and we start to say, what's the role of education in this and what can that contribute? So it's just trying to map it. So it'd be helpful if we saw that back here, saying that across the whole partnership economy, which is more than health, public health and social care, isn't it? It's more than that. How we're going to tackle this and the timescales, but really welcome it. Thanks, Chair. Back to you.
Thank you. If it's possible to respond to that. So absolutely, Chris, and I think that in terms of the tobacco control group, so you're right, I kind of, it's putting that energy into a 12-week to say this is possible. I think around smoking cessation, people, it's really easy to think, gosh, we're not making any traction on this, but actually the data is showing that for every 2 people who are referred into smoking cessation, one of them is going to set a quit date. For every 3 people who set a quit date, 2 of them are going to quit. And then if you've quit at 28 days, you're 5 times more likely to have quit at a year, which is a really big marker. And I think getting that data out to show there is a purpose, and there is really good evidence that if we can put this effort in, it will result in positive changes to people's health. So that's creating the hope, I think, is feels really important. The exit routes, you're absolutely right with what you're saying, Chris, there, is that we are trying to set into place the sprint with an exit route and the tobacco control strategy route, which the local authorities have been absolutely fantastic in saying, you know, this is what we've got in train and this is how we're going to be taking it forward. That will provide the longevity, which is where, you know, thinking about things like what's the role of education. Really kind of gritty issues we've also been discussing is around, you know, policies on vaping. You know, what's our stance at a system level around vaping? So that is where the longevity will come in through that tobacco control group. So that's what we're testing. Does this work?
Thank you. Carol?
Yeah, no, thank you. I mean, as far as sort of the Derbyshire County Council perspective, I mean, we've got a great team in public health on stop smoking, and the figures have been coming down. They do some terrific work, mentoring and, you know, being available and advice and everything else. And despite COVID, when I thought it might go up again, actually, the figures have still started to come down again, but it's still a long way to go. The problem we've got is, well, we've got now the new government legislation and there is some money coming down, but we're not quite sure how it will be divided, whether it'll go into the public health or some for trading standards, because a lot of it as well is getting rid of the illegal vapes and everything else. And we're also now in Devil in the Deep Blue Sea, because we put a press release out about the work we're doing on stop smoking, and one of the local papers put a headline, you know, that we're advising to stop vaping. Well, actually, we don't want people to vape, but if they're smoking, vaping is better than smoking. But we don't want, you know, so it's how the communications, when you say about communications, it's getting that wording right. They took it sort of slightly wrong. It was corrected, I will say, but, you know, we are in the Devil and Deep Blue Sea. Vaping is better than smoking, but please, you know, don't vape if you've not smoked. And that's the problem we've got with the young children, with all these fancy ones, with the, you know, the different flavours and the pretty packaging and everything else. It's an absolute nightmare for us. And I do think trading standards have got an awful long, you know, good part to play in that as well, to try and confiscate and stop some of those. But it is a priority, and you know, fully endorsed. I think it's great work. Thank you.
Thank you, Carol. Yes, I'm aware that Derby City's trading standards team recently did a major haul, I think, of illegal vapes from somewhere. So first of all, I've got, I think, Ellie, and then it's Christine, isn't it? Hello. And over here, so I'll come to you in a minute. So Ellie, thank you.
Thank you, Chair. So I just wanted to welcome also the focus on smoking in the stay well element, and we've looked at the different drivers, worked closely with Jane and her team around looking at that, and agreed that smoking is something we really want to focus on. It's a driver for all of those diseases that cause the greatest burden of premature mortality in the county. And I think the key challenge for the partnership, as Chris has reflected, will be that this sprint or this initial focus on smoking leads to something that then is a foundation for us to build on and to really bed into the system in terms of, you know, smoking's been business as usual for quite a long time, but there's a renewed focus on smoking nationally, and this is our opportunity, utilising the strategy, to think about how we integrate and how we work more closely together and how we build on the opportunity that's coming through the new funding that will be coming into Derby and Derbyshire. So the key test of this will be how long it kind of lasts, the effect of it lasts. So the sprint being that sprint at the beginning, but as Chris described, that marathon, how are we going to sustain that focus on smoking in the longer term in order to have the impact that we want and need to have.
I don't know if you want to respond to that, Jane, or did you just like that coming out there as a question?
No, I think completely aligned with what Ellie's saying there, yeah.
So the question is, how do we sustain a longer term focus on, and are you suggesting cessation or prevention or both? Because as Chris Leighton said, the health messaging is really important, isn't it, on this?
I think smoking is the new smoking, as the saying has been lately. So we've kind of, cigarette smoking has been one of those things that has very much been considered business as usual, and so there hasn't been that focus and energy behind it. It's still the leading cause of premature mortality across the county and city. So I think it is about this partnership holding us to account to see how that is embedded and how we are actually tackling all the aspects of smoking. So we've got additional funding coming. We don't know how much, as Councillor Hart said, around trading standards, which is about tackling illicit tobacco and the sale of illicit tobacco. We've got an increase in our cessation services. We really need our health and care system and wider partners to be driving footfall to those services, so encouraging people to take up the offer of smoking cessation. So there will need to be a multifaceted plan strategy that we then are held accountable for delivering.
Thank you. So if the room will just bear with me a minute. So on this issue of we've got the strategy for dealing with smoking cessation, but when we think about prevention in the sense of deterring, I mean, personally, I do think smoking we have stigmatised smoking quite successfully as a society. So as I think Jane indicated, this isn't an area where you're starting from scratch, and a lot of good work has been done, a lot of previous publicity campaigns. But nevertheless, there is the issue of the vaping and what that means. And I know Derby has worked with schools, and I'm just thinking as like, they're trying to think more broadly in terms of how an integrated care partnership works. I mean, what engagement does the population health management team have, or what channels are there to engage with schools, youth organisations, that kind of thing, to try and deal with this up front rather than, and also the question sort of related to that, as I wanted to ask, is the voluntary services, the voluntary sector, do they have a presence on the population health management steering group? Ellie, do you want to respond to that, or Jane?
Yes, so Wynne colleagues are on the population health management steering group, and so smoking is the first area of focus. Really closely engaged and really welcome the insight that the voluntary sector voice gives to us. And then once we transition this smoking cessation into the tobacco control group, which provides that longer term focus on smoking, then what we will start to do then is turn to go, okay, so what is the next driver that the population health management steering group will begin to focus on, again, to support the key area of focus around prevention, early identification of those three areas. So we will keep changing our focus in a sprint approach, but every single time we need to get the exit, and the voluntary sector are going to be key partners throughout all of that.
Thanks. So I'm just going to, sorry, but bear with me just because on this particular point, because I think this is about thank you for that answer. That is very helpful. And I'm just thinking about the whole education system. I mean, maybe this is something to think about outside this meeting, but Robin, we've worked with them in Derby, haven't we? Is there some way that we need to have them more formally involved in an integrated care partnership agenda, or is that not appropriate?
I think, yes, we have done quite a bit of work over the years, and more recently with schools around smoking and around vaping. But I wonder, as we move towards the Tobacco Control Board, which it's going to have the direct impact of tobacco dependency treatment services, but it's also going to have the breadth of tobacco control in there. And I wonder, Ellie, whether that's where that stronger engagement with schools would come at that point as part of that. There's a section of the strategy that sits here with the ICB around that tobacco dependency and treatment of tobacco dependency, and then there's a broader aspect of it which I think sits more around the health and wellbeing boards through the tobacco dependency board, which is around including trading standards as well, and schools and other broader partners in that think, but obviously Ellie's board.
So the board is, there was a board, and under the changes that we've had through the integrated care system structures, it stopped meeting. So we are reinvigorating that board. We're looking at the membership of that board. So that's absolutely what we'll be thinking about who are those key partners that we'll need to have around the table.
Excellent, thank you, Ellie. I'm just asking these questions because I think, what we need to do is focus on what the issues are and then keep on thinking, as Chris indicated also earlier, is who is talking about this and what can they also do? Because we know that health and social care can't influence all these behaviours anyway. We can't determine. So we can influence them, but we're not the only people who can influence them, and we can't determine them. So yes, thank you. So that's really a helpful answer. Thank you. Richard, I'll bring you in a minute. I've got Christine first, and then gentleman over there.
Thank you, Chair. Christine Durrant from Chesterfield Borough Council. I'm also Chair of the Chesterfield Local Place Alliance and the Health and Wellbeing Partnership. And I guess my question is, obviously in the paper, we're probably at too strategic a level to think about that locality area. But at some point, I assume in your action plan, there'll be a request for those partnerships, which include, a whole range of partners across the boroughs, to lean into this project and have it on our agendas, because at the moment it's not up there as a priority.
Yeah, thanks very much, Christine. So if I just respond to that. So you're absolutely right. The method of delivery will be through place to make sure that we are really engaging with people at the local level. And because when we think about what are the evidence-based interventions and where are they cited and how successful are they being, that local knowledge of different population groups and how they seek to access services is only going to come from those really local place alliances. We took, in terms of the development of the idea, we brought it through the 2 integrated place execs. So for Derbyshire and Derby City, we haven't taken it lower than that. And you're absolutely right, Christine, we need to make sure that we do that quickly.
Yeah, thanks. So I'm Drew Smith here representing the GP Provider Board instead of Duncan Gooch, despite what the nameplate says. I know we're at a strategic level at the moment, but given the sprint issue and what's also been mentioned regarding resources, what's the vision on how we achieve tangible differences in delivering these services where the need is greatest? And as part of that, what is the strategy for communication to ensure that patients who do not communicate in verbal English as their first means of communication are not missed out, given the sort of incidents that you described earlier on and the prevalence and amongst those groups that will be higher than others? Thanks.
Thanks, Drew. Whenever I get a two-part question, I always worry I'll forget the second part, so bring me back if I do. So the first part, so Ian Potter and Dr. Andy Martin and Ian Potter are really closely involved and have been phenomenally helpful in this area. So they are really holding us to account in terms of how do we make sure that that intelligence and the action that is needed is taken through into the primary care settings. So that's definitely in train. The second part of the question was around how do we make sure that we engage with local people. So the vision, Drew, and you'll appreciate the nuances around this. So the vision is we just stick with, say, the tobacco dependency programme, or we stick with straightforward smoking cessation programmes. We know they work. The evidence shows they work. What could be happening locally is we have those services and people aren't, as Ellie says, being driven through to them. And that might be because they're not aware of them. It might be because clinicians who are coming into contact with people who are smokers don't feel confident to have that, what is a really difficult conversation in the time frame that you've got. Or it might be that the information that is given is not given in a way that is clear, so down to health literacy is not giving in a way. So now we feel really confident that we have a great understanding, because we've done a big evidence-based review of a hierarchy of evidence as to what works. What we are now looking to do is to say, so where have we got that in place across the city and the county? And if it's not working, what are the issues around quality conversations, so the competence and confidence of staff to have that conversation, and then health literacy, the verbal, written and digital communication that we're giving, that means it needs to be tailored to those population groups. And it always sticks in my mind when, you know, health literacy is something that really came onto my radar probably about 2 years ago. And quite a stark fact that sticks in my mind is 50% of people within Derby City do not have levels of health literacy that will enable them to usefully engage with health information that is provided to them. So we have got to tailor that information, because if you take it in its broadest sense, every 2 people that a GP is saying, unless we tailor how we give that information, one of them is going to walk out and not understand what's been said to them. So you're absolutely spot on, Drew. And what we've got in as part of this key area of focus is great connections into quality conversations, health coaching approach, and then great connections into health literacy. And plus the local insight voluntary sector and the really valuable contributions. You know, I want, you know, hats off. Ian and Andy have really helped us with this. So thanks.
Thank you. You're absolutely right. We know there's an issue with communication around health, and certainly in Derby, speaking just parochially for Derby at the moment, don't be Robin. And we have talked about this as part of our health inequalities agenda, and it's something we're going to keep our eye on. Through public health and through the Health and Wellbeing Board here in Derby, because we know it's a big problem, not just for native speakers of other language, but for native speakers of English. Thank you. So Richard.
Thank you, Councillor. I think my questions have been answered in the last 2 questions. Funny enough, I was going to ask about different techniques for accessing different groups, and presumably different things work for different groups. And in an intense sprint, can we accommodate that? Is really what I was saying, because I think we'll need to, won't we?
Yeah. So I'm not. So I'm not going to make any promises we can accommodate that in the sprint, but what we are really focused on, and Sean's here, who chairs the comms group, is we've got a two-level approach in our comms. One is general population coverage of straightforward messaging around smoking cessation, so or around smoking, and trying to make it the positive of not smoking as opposed to the negative. So really thinking about the psychological approaches, the behavioural insight that leads to changing behaviour. The second part is, so that's one level, and then the next level is what are the tailored communications that we need to give to the different population groups who we know are at higher risk, so that we have got tailored information. So that's the approach that's going through comms, and we've got clinical psychology in there so that they can give us that behavioural insight, so that the comms is absolutely finely tuned to what the evidence base says around how to engage with different populations. So I'm not going to promise that's all going to be done in that period of time, but the intention will be that the comms will flow through to the tobacco control group that Ellie's talking about, because it's one of the three groups we've got running: comms, delivery and strategy as part of this sprint work.
Can I just add, I'm pleased you answered, you touched on the psychological side as well, because I know you're all going to think I'm thick when I say that, but I didn't stop smoking because I knew it was bad for me. I stopped smoking because it was affecting my sport. Do you understand? Yeah. And so it's a bit like drinking, isn't it? I didn't cut down my drink because it was bad for me. I cut it down because it affected something else that I really valued. Yeah. I suppose it's that psychology of how you approach these people. I just wondered how important that's going to be.
Hugely important, and absolutely right. Different people's motivation is maybe not what we think it will be, and that's why it's so important to get psychological insights in there. Thanks.
Totally endorse that point, Richard. Totally understand that one. Thank you. I just need to bring in the guy at the back, and then Chris. Thank you.
Thank you. Chris Pienaar from Derbyshire Autism Services, but the Derbyshire County representative on the VCSE. Thank you. So also just welcoming this initiative, thank you, and especially the targeting and the evidence-based work involved in putting it together. And also just touching now on what Richard just mentioned in terms of different things for different groups. There's increasing, I won't say evidence, but certainly anecdotal evidence very strongly, coming up in neurodivergent communities in terms of, especially where condition is genetic, that some of the previous wisdom might be slightly off. So, for example, on CBT, which is so brilliantly effective, and an increasing belief that it's actually can be quite damaging for some neurodivergent individuals. And I wondered, in terms of this, with neurodivergent individuals, the substances are often a step that is followed because of an inability to engage effectively and assisting with that, and also the price paid for engaging, and spoons of energy, etc., etc. So if, for example, that alternative isn't there for those people, where do they turn? And so there's so I suppose the point is the research into that. And in terms of evidencing and research, is that actually correct, number one? And number two, could some focus be put into research to look at what alternatives could there be that are not damaging and causing people to become dependent on them? Thank you. The only other one was the there were two shared systems that you mentioned much earlier, and absolutely. And of course, there are many fantastic pilots going on with the voluntary sector that are coming through the ICS and joined up Care Derbyshire. And of course, that ability trying to integrate all the systems, it's not straightforward. So that's also welcomed, what you mentioned there, but also just a request that those don't become punitive. In other words, you can't even bid for it if you haven't got X, Y, and Z, but rather collaborative, co-producing the joint system so that everyone has access. And lastly, the Chair's reference to resources becoming shorter and shorter. So just another prompt that the third sector is vast, the voluntary sector, and to be able to point commissioning to leveraging those resources is an excellent way of facing problems where budgets are going to be dropped radically. Thank you.
Thank you. If I can just pick up on, so the first point is fascinating and I don't know the answer. What you've made me think about is a conversation that we had yesterday with colleagues from the Healthcare Trust, who, it's a similar, what they were alluding to is something similar. So when the smoking cessation came into place within their inpatient settings, people with severe and enduring mental illness who had been, who were being retained within those facilities, when they were not allowed to smoke, then they saw a slight increase in violence and aggressive behaviour, because that was, that is a coping strategy.
Yeah.
And I think you're alluding, you're making me think about that. So fascinating. Thank you very much, and I'd like to connect in with you after.
Thank you, because those decisions are involuntary because they're wired into the brain. So there isn't really a choice in the case of many neurodivergent conditions, say genetic. Thank you.
Did you have any more to say to those, Jane? Did you want, I'm going to need to bring Chris in a moment. I'm just going to take a couple of comments, and then I'd like us to focus very specifically on the request in the paper to look at items for escalation at the end of the report. But did you want to come back in on Chris's points, Ellie? So I'm going to bring Ellie in first, Chris, and then...
Thank you. So I actually wanted to come in around Christine's point earlier as well. So the tobacco discussion is on the agenda for the County Place Partnership Board tomorrow. So that's the start of those discussions with our borough and district colleagues, voluntary sector partners and local place alliances around how this agenda can be supported across our different places. And also just to pick up on the points that have been raised about targeting particular groups and some of the challenges. Some of the funding, a small amount of the funding that is coming to local authorities around stop smoking to increase services, there's also a small amount of that that's available for insight work and campaigns. So we'll be looking at that in the Tobacco Control Board, about how do we target that and how do we use that opportunity to really understand some of the challenges for particular groups, and then to think about how we target that through tailored campaigns.
Thank you. I'm going to, Chris, and then I'm going to let you come in, and then I'd like to move to the 2.3. Thank you.
Yeah, thank you, Chair. Just been listening to the conversation, and I can't understate how important this is. So I think what we're being asked is to say that the ICP supports this approach, tobacco reduction, smoking reduction, get the right language, as our priority area. I think what I'm trying to put in is that the inference is this isn't just a stock take of what we're all doing. We're being asked as a partnership to go a bit further. And I think that's an important guiding principle. We're not just going to accumulate what we're all doing at the moment. We're being asked to go further. And on the assumption that Health and Wellbeing Board also adopts this as a stay well, we're asking the Health and Wellbeing Partnership to go a bit further. So my ask is that we support the group, the review group, to have the sprint. We need to be really clear on, we want to see what the action plan is and which partners can go a bit further. And I think that would be really revolutionary. I'd really support that. Thank you.
Thank you, Chris. That particular phrase isn't in the recommendations. Go a bit further, but it's a good motto for life, isn't it? But it's a good proposal for this report as well. Thank you. I'll come back to that in a minute. I'll just.
Thank you. I think to some degree, Chris and Ellie have just picked up those bits from my perspective. I think what it's really important is around the communications particularly, is that because we haven't yet gone to the place alliances and to those local places, actually potentially we could miss the community members and the connectors within our communities who are able to have those conversations that health professionals perhaps aren't. So actually, if we start the sprint without the action plan in place and we don't have that broad buy-in, we're going to be a slow starter. I can't think of the word to take us to sprints. But actually, if we start the sprint, I think it's about making sure we do it in a very timely way and having that really clear vision, I think, and making sure that we bring communities along with us rather than this being something that becomes an afterthought. So comms, particularly, and engagement, I think is vital from the outset, and how we involve voluntary and community sector, community connectors as well, and those networks that we do have is vitally important. So absolutely behind the work that Jane and we as a team are doing. I just think we have to coordinate it from now in order to make it from strategic into action.
Thank you. Do you want to come back on that, Jane?
No, I couldn't agree more, Kim, and certainly the Martin, who has Win has really kindly a member of the voluntary community sector is closely linked in, so we need to work out about how we make sure those comms are coming out, Kim, but completely agree. Yeah.
Thank you. So in the spirit of, I assume the room is quite happy to accept Chris's proposal that we all work in the spirit of going a bit further. Okay, that's unanimously agreed. I think the report asks us to look at the escalation points on page 6 or 11.1. And suppose, so you have touched on some of this, Jane, already, haven't you? I think the reason we might want to spend a minute, we will move on, we do have time in this meeting, don't worry, I'm mindful of time, is to look at some of these, because I think they might sort of touch upon, well, we've already talked about resource, haven't we? You've talked about data, and you've talked about access for particularly voluntary and community groups into systems. And these are sort of factors that I think will pertain to all areas of partnership working. We've also touched on the issue of resource. So, but you have, those are all things that need to be addressed. So, Jane, would you like to take us through 11.1 in detail, please, and explain them in more detail, and say if you have a particular ask of a certain area of people in this room, or anything that the room could support you with to escalate and complete these issues that you raised there. Thanks.
Thank you, yes. So in terms of the first point, what we were looking for support from the Integrated Care Partnership is the approach that we are adopting, that the Section 251 application will be conducted as a population, to use data for a population health management purpose, rather than as doing one for smoking cessation, one for substance misuse, one for any of the other behaviours, maybe people who identify people in benefits and target people who are on benefits for maybe some of the reduction measures that we would want to put into place. So I think it's that support for, does it seem sensible that if we do a 251 application, working with colleagues in the ICB and within our kind of partner commissioning support units, that we put in that application for population health management purposes, not for the purposes of smoking cessation as part of the Stay Well, because that will be to the benefit of the system. We wanted to kind of to get agreement on that. Do you want me to take them one at a time?
No, I'll take that one.
Yeah.
I'll take them one by one, if that's okay with you. So is that just something that you need a sort of sense of agreement with?
Please.
Yes. Are people happy with that approach? At the back, would you mind saying your name and where you're from, please?
Yeah, I'm Jonathan Davis from Chesterfield Borough Council. Sorry I was a little bit late. I just wondered whether you could say a little bit more about that. Would that identify people at a patient level to other stakeholders in the system, or does it just present a body of data, or it's not something I've come across before?
And I think, and the honest answer is we've been battling with this, and as we've begun to unpick it, it's in the last maybe month or so that we have really come across this 251. It's a different part of the country that have used this approach and have got agreement. So the intention is, dependent upon the breadth of the 251, what it allows
Jane,
us to do.
really sorry, but could you speak to the mic?
Sorry,
I know it's
yes.
very antisocial, but because we're being recorded, if
Yes.
you don't speak to the mic, the recording doesn't pick it up.
Apologies. So in terms of the 251 approach, we are following the lead of a different part of the country. So Nottinghamshire have taken this approach and have managed to successfully get an agreement for a 251. What it means is that data that has been collected for individuals, which would be useful to use for population health management purposes, but may not have been collected for those purposes, you can utilise at a system level in order to support proactive care of those patients. So if we did want to take it into account of, I'm thinking about the information within the second tier local authorities that would be useful. So assisted bin collections would be useful information when we think about vulnerable people. People in receipt of council tax benefit would be useful information for collaboration for population health management purposes. So in its broadest sense, that is what this is intended to do, so that every time we think of an approach to reduce health inequalities and to drive forward prevention, we don't have to start from scratch of, are we allowed to use this data for this purpose? If we can get an agreement of Derbyshire is wanting to take a proactive population health management approach with its partners, and I'd have to check whether the second tier local authorities, the first tier local authorities have definitely been involved in those conversations. I'm not sure that the second tier have, so again, that's a really good prompt to me to take that back and ask the question. But whoever is involved would then be able to utilise that data for population health management purposes, so to improve proactively the health of joined up care Derbyshire people. So hopefully that answers the question.
Thank you. Yeah.
Thank you. It's I think so. One of the things that you said in the earlier part of your presentation, and I think we would all be sort of anecdotally aware of this, is that there is an under-reporting of smoking, and I guess that's because when you take a mortgage out, for example, and you have to take the insurance out, they say, do you smoke? And I'm guessing that if you did fall ill through smoking, for example, and then the insurance company wanted to see your medical records, and it turned out that you'd been less than candid with them, that they wouldn't pay out. And I just I'm acutely aware that, you know, all of these things, that I guess across all the things that we do, largely works on trust, and if people felt that their information was being shared you know, beyond what they might expect it to be, it might firstly make them even less likely to report this, but also undermine you know, the wider work. But I take what you've said, it's very useful. Thank you.
Yeah, and if I could just respond, you're absolutely right. So there is always a trade-off in terms of gathering of this information, and as part of the 251 arrangements, my understanding is that you have to do a privacy impact assessment, and the content of that privacy impact assessment, the detail within it would obviously touch upon those kind of ethical issues that you're talking about there, that you're absolutely right to flag. For some people, this opening up of data may cause concern. So as part of the application, it's not a given that if we put this application in, we will get it. We're just trying to follow the lead of other partners in different parts of the country, and recognising at the moment we always manage to get so far and then stop because of the information governance kind of barriers that are in place.
All right, so I think we can, I would have taken it as read that all data protection issues would be covered in such an initiative, and there'd be quite strict regulations around the sharing of data and the ethical use of them. And you, before I bring Chris in, you're just going to guarantee to his now Jane, that is the approach that the group will be taking. Thank you, Chris.
Yeah, thanks, Chair. I really recognise why you're asking this question, and I think 3 or 4 of the escalation areas relate to information or data and digital tools, really. I think there's a risk in asking what is a really big question within the paper around, can we proceed to a sprint? So I think that first question around population health management and information warrants a conversation in its own right about how are we all going to get behind this, and it's worthy of a good hour's dialogue here and in the Health and Wellbeing Board on that question, and having been able to have the conversation, because data issues can really grind us to a halt if we're not careful and we've not had the right conversation. So for the purposes of the sprint, and for the information you need for the sprint, which is the paper, absolutely, completely support. There's a bigger conversation for us to have around information, our population health management approach. And I think there's a risk if we try and put it into the end of a paper. I think there's a risk in that. So my advice would be, for the purposes of what we're trying to agree today around smoking and tobacco and the Stay Well objective and the sprint, absolutely. Should we have a bigger conversation in the 2 partnerships around our population health management approach and information? and give it really due attention. That'd be my advice. But back to you, Chair.
Thank you. That seems a very fair approach to me. Does anybody else want to comment on that? No? Jane, do you want to? So what are you proposing for, in what forum would you think that those conversations should take place, Chris, just for the sake of, we are creating a forward plan here now today.
Yes, so I genuinely, I think 11.1.1 is an item in its own right and worthy of a conversation at both the Integrated Care Partnership and Health and Wellbeing Boards. For us to have a really transparent conversation around the partnership commitment to information and data sharing, and I think it needs it. My advice would be that we agree these principles for the purpose of the intent around the sprint and the tobacco reduction programme, and come back to it for a broader population health management conversation. That'd be my advice to keep it on the right path.
Thank you. So is everybody in the room happy with that proposal? Jane? Yeah? Ellie? Everybody else? So it is something we might maybe perhaps consider perhaps for the next meeting. It's obviously going to be a very foundational thing in relation to partnership working. So we'll look at when we can bring it back, hopefully fairly soon. Thank you. So in the wake of that conversation, Jane, do you want to go through the other 3 points? What would you like to raise from the other 3 points that we haven't already covered, please?
So I think that separate conversation will wrap in the other, well, certainly point 2, so we can pause that one. The third one is just around a recognition. So this is around an escalation, and just, I suppose, we are trying to work away in the background to try and find a way around a technical issue, which is when we are sitting practically with key partners, very much so the voluntary sector, there are some methods of connecting, like we use Teams to do project management, and we can't give them access to our Teams channel, so they can't get into the files in order to access project management documentation. So what we are trying to do is to work really closely with our IT colleagues to open up those channels. So again, it's just that recognition that we talk about integration, but going with integration means we need to lean in and support partners to be integrated with us. So I think it's just that support for that feels like the right thing to do, and we should be putting energy and effort into it.
Okay, thank you. Would anybody like to come back on that particular point? There's no specific ask, Jane, at the moment in terms.
I think I suppose there's an ask of if anyone's got this cracked, how do we, if someone's got a Gmail account, how do we get them joined to an MS Teams? Because at the moment we can't, and a lot of voluntary sector partners do not have official email addresses, and that's excluding them from really important work.
I think I'd just like to really welcome what Jane's just said, and I think it is really important. A lot of our colleagues who are very much part of the system and our partners in this aren't able to equally access the discussions and input. So we, as a system, I believe that we need to find a way to enable that to happen. I think also with the bigger IG debate, that's really, really important because actually we're always coming from a back foot in that as a sector, we don't have the same population health management information, very often don't have access to data sharing. And it's one of the things I think if we are going to be an integrated system and we are going to be equal partners in terms of that system, then need to be able to facilitate that access.
Okay, thank you. Just Alison and then Chris. And then...
Thank you. And I think probably all of the four were, I think there are clearly issues that we're facing in Staywell, but I think we're acutely aware that actually they are cross-cutting issues, I think, for each of the key areas of focus and probably kind of wider approaches to integrated working. But I think Chris's point is a good one, as they are cross-cutting, and I wonder if actually part of the ask is that consideration in the round, actually what are the real practical issues, whether it be IG, data sharing, kind of practical IT issues and resources are all things that we need to discuss and consider. And I wonder if we have perhaps one of these meetings that is focused around those and us kind of working through those in terms of getting a way forward, because I absolutely agree. I think they are cross-cutting issues rather than
specifically stay well issues.
It sounds like a very good plan to me. Chris, did you?
Yeah, it's just the same point. This is an enabler for the integrated care strategy as a whole. So it warrants a conversation around digital access across a broad partnership. It's a really material issue. There are reasons why it is not so, and we all are keen to protect our information and our systems. There's a reason why, and we need to be mindful and work out what permissions we need to go outside of those arenas. So I think, and with Alison, it needs a conversation in its own right. So the agreement would be, for the purposes of what's in front of us, that we have to have a practical solution to enable the sprint to happen around information sharing. We have to create a safe mechanism for that to happen to enable the sprint, but we need a bigger conversation around how we create integrated information and digital systems. Thank you.
Okay, thank you. Right, I'm aware of the time, so I think we've come to a useful conclusion there. So thank you very much, Jane and the team. I think you've highlighted a key behavioural issue that has been addressed but needs to be readdressed. And I think it has illustrated really well for us what some of the key problems are, the stresses in the system for working together. And so what we will do is come back relatively soon, I hope, with a specific focus on those intra and inter-system working issues. So for now, I'd like to thank you very much for that report. We've spent lots of time on it, but I think it's worth it because the point at the moment is we need to have an understanding of what the broader system issues are in terms of integration and working together. And that's been really helpful from that perspective as well. Thank you. So moving quickly on then, I'm going to introduce Robin Dewis, who's the Director of Public Health at our Derby City Council, who's going to talk about tackling the effects of drugs and alcohol and give us an update on the work of the Derby and Derbyshire Drugs and Alcohol Strategic Partnership. Thank you.
Thank you, and oh, well done, Lynn. Just pulling the slides up. So the purpose of this conversation is partly to share the work of a partnership that is established in an existence but is sitting quite separately from the Integrated Care Partnership, and to establish some relationships between the two. So Dame Carol Black published an independent review of drugs, a 10-year drugs plan through 2020-2021, and developed the 10-year strategy from harm to hope in 21. And the purpose of this was to identify additional resources, but also to bring partners together in order to, as described, combat drugs. So combat drugs and the effects of use of illegal drugs on populations. And we were tasked locally with developing one of these partnerships, with having a senior responsible officer, and to develop a needs assessment and understanding of what the needs of the population were. So I was established as the responsible officer for that, and we felt it was appropriate to develop not a combating drugs partnership, but a drugs and alcohol strategic partnership, acknowledging the role of alcohol that we needed to consider within this. Is the next slide, thanks. And there are some national asks through the drug strategy for the partnership, and the three key ones are across the top of that table there. So breaking drug supply chains, delivering a world-class treatment and recovery system, and achieving a shift in the demand for recreational drugs. And I realise I don't have my glasses on, which is, apologies. And if I just draw your attention to the bottom of that table, then some of the key activities that we need to achieve through the partnership is around closing county lines, disrupting OCG activities, preventing deaths, establishing increased high-quality treatment places, and reducing overall drug use. So they are the themes of the role of the partnership. And if we just look at the left of the slide there, so we can see the key partners involved within the partnership. So as you can imagine from those priority areas, we've got the police and probation and the Police and Crime Commissioner who are linked into the partnership. From a local authority, we've got adult social care and children's social care and public health, and then we've also got NHS partners within that partnership as well. Next slide. Thank you. And from a health perspective, obviously, drug misuse is a significant impact on the health of the individuals who misuse drugs. But actually, when we look at a system perspective, alcohol is the thing that has the greatest impact, which is why we wanted to include it within our partnership work. And this is just really summarising some of the costs of alcohol and the impact of alcohol on us as a society, and a really stark figure there of the estimated annual cost of alcohol to the NHS, 3.5 billion a year. If we look at those negative impacts on society, we can see they spread along health and well-being, prosperity, and also the criminal justice as well. And there's some significant impacts on the health of individuals and families within those areas. Next slide, please. From an individual perspective, I think from an alcohol perspective, we know some of the key aspects and the harms and the risks of alcohol. There's some things in there that actually we don't think of so often. So particularly some of the increased risks of cancers, particularly of breast cancer, and harm when pregnant women drink, and also impact on heart health as well. So there's some really key things in there that we don't necessarily link immediately with alcohol. And when we think about the harms of drugs, again, it's much broader than the immediate things we think about when we think about mental health and about overdose. There's much greater impacts from the risks of illegal drug use. Thanks, Lynn. When we're thinking about costs from a health service perspective, this is just a summary of some of those alcohol costs that were drawn together in the previous slide. So we know that there's a significant impact on emergency services. And when we use the term alcohol related, there's two different terms, alcohol specific and alcohol related. So alcohol specific would be something that we would look at and describe as a direct impact of alcohol misuse at that particular moment in time. And alcohol related is related to the long-term damaging effects of alcohol. So we can see there's a considerable amount of emergency activity, of secondary care activity, mental health activity, and also we can see that within primary care, potentially there's contact with a high number of dependent drinkers who are not necessarily identified, but actually if we could identify those individuals and move them into treatment, there would be a great benefit for them. So far through the process of a needs assessment, we've had the findings that have come from the local authorities, from the County Council and City Council. We've had some findings from the police and also from the probation service. And there's currently some work ongoing to develop the summary of needs from NHS services. And this is just a summary of what's coming through from those pieces of work by the individual organisations. So we can see that particularly for Derby, we have an issue around alcohol, both alcohol specific and alcohol related hospital admission rates. We are much higher than the national and the regional rates. And that when people are admitted to hospital with alcohol related problems, that we lose people. So even if people are identified, we don't necessarily then follow those individuals through into treatment services. Derbyshire has the highest number of drug-related deaths in the region, and that's significantly increased from 2020 to 2021. And 87% of people entering alcohol treatment and 62% of people entering drug treatment were identified as having a mental health treatment need. And this is something we were able to be at a conversation with the Healthcare Foundation Trust this morning, talking about how we ensure that people who have mental health problems, are, if they have drug and alcohol issues, they're identified and put through into treatment, and equally the other way around as well, so that people in those two services can achieve the benefits of the other. And also, sorry, Lynn. So we had an observation that the population in treatment doesn't reflect the ethnicity, particularly within the city, and there's more work to do there to understand whether that's about unmet need or whether it's actually meeting the needs of those populations. And just on the right-hand side there, one of the things that we have identified particularly is not just that attrition from people being identified within hospital services with alcohol misuse issues. Actually, on the right-hand side, you can see that people are identified also through probation with alcohol and drug use, but only, again, a small proportion of those people end up with either a drug rehab requirement within sentencing or an alcohol treatment requirement within sentencing. So there's a lot more that can be done to ensure that that information gleaned within those services ensures that people are passed on into the right treatment programmes. Thanks, Liz. So the priorities as they stand at the moment are as described on the slide here. So striving to increase numbers in treatment. Now we have significant investment that's come through national funding for both the City and the County Council for drug and alcohol treatment services. So we have an increase in capacity, and we're really keen to work with others to ensure that we can identify people who would benefit from treatment and to ensure that they're offered and can access that treatment. We're specifically seeking to decrease the deaths from drug overdose, and part of this work is ensuring that we roll out naloxone, and that's widely available. So for those who aren't aware, naloxone is effectively an antidote to opiate overdose. So people who have taken an opiate overdose, if they're given naloxone, it can reverse those effects and allow time for people to receive emergency medical care. Improving the quality of services, so particularly thinking, as mentioned, about those pathways, so between hospital, between prison, between the community, how we improve those treatment pathways so that people can get the benefit of the increased investment we've got in those services at the moment. Understanding the unmet needs of our alcohol users and why people don't come forward for treatment or why they don't access treatment. And a theme, obviously, is at the end there around sharing information. So how do we identify and provide a joint response to the hotspots where we see that there are issues developing? Thanks. So for the ICP today, the key recommendations, firstly, it's to acknowledge the work. So just to have been able to update you today on the work, and also for you to see the strategic direction and the priorities that have been developed through the work of the DASP. To support the engagement of NHS colleagues and of local authorities into the DASP, and to support us in determining the local need and identifying the strategic priorities. To take note of those strategic priorities that we've already identified so that we can ensure that they are built into other strategies and plans where that's appropriate, and particularly thinking about those identified around alcohol or around pathways. And just a request that we can bring an update from the DASP at least annually. It might be more frequently if there's more to say, but at least annually. And to propose that we work more closely with the Integrated Place Executive in order to look at how we deliver the strategy. And I've had conversations with the chair of the IPE, and she's happy to take that forward as well. Thank you.
Thank you, Robert. If we could just hold that slide there, please. Let's see. So, are there any comments or questions or observations for Robin? Yes. I'm really sorry, but when you first spoke, you didn't say your name and who you're from, so I still don't know your name.
I'm sorry about that. Kim Harper, Community Action Derby. too far away.
I do know who you are.
Thank you for that, Robin. I'm really interested to hear about the report, actually, and I haven't read the report, but I guess from my perspective, has there been anything in there around prevention and why people are turning to drink, and actually how we sort of the upstream, if you like, particularly in terms of the community end of it, and is that incorporated within the DAS strategy?
So it's a really good question, and so what I would say is there's a direction requirement from the national team around what we must think about first within this work. So our first task is as described within those headlines, but the ambition of the partnership is absolutely to develop that and to move towards those prevention activities as soon as it is possible. It's always that challenge of balancing the national requirements around the funding that we've received and delivering. But part of those really early conversations that we've had are around how we work much better, as mentioned earlier, with schools and get that engagement with young people, which isn't technically part of that, but we want to make it part of that.
Thank you. Any other comments or questions over there?
Thank you, Chair. I'm Chris Warner, the Chief Medical Officer at Derby and Derbyshire ICP. So I want to lend my support to Robin's proposal this afternoon. I think it's important that we recognise, and I know Robin's drawn our attention to it, that drugs and alcohol related issues affect not only the individual, but also affects the wider society. Drugs and alcohol will impact upon the wider family, an impact upon people in the wider community. It impacts on the safety agenda of many, many people. And what does that mean? It means actually that these issues, even if you don't drink, even if you're not using illicit drugs, they're going to impact upon you. And so, I think it's really important that we recognise the value of this work, the importance of this work to individual patients and to everybody else in the community, Chair.
Thank you. Anybody else want to come in on this?
Thanks, Chair. It's just a link to the previous important item. So I think what we're saying here is we're raising the awareness of the work that's ongoing across the partnership in different areas. We're recognising the importance of it, and we're going to get a greater understanding and make sure we are, each of us, delivering our duties around this. But it's different to what we were saying previously around smoking, where we're going to go further than that. So it's being clear, because we've got a limited priority portfolio that we can all get behind. So I'm just checking that this is about raising awareness of what we're doing, making sure we are doing our business as usual activities as well as we can in this space. But Robin, are we being asked to go further? Because there's a point about having a priority for us, and we've just agreed on Stay Well, our priority is tobacco and smoking. Thank you.
Thank you. So this is an area of work, as there are other areas of work similarly, where the leadership is sitting outside of the Integrated Care Partnership, but there is work that the Integrated Care Partnership can contribute to in order to increase the success. So if we go back to the Integrated Care Strategy, although our key focus, particularly at the moment, is around smoking, one of those turning the curve outcomes within the Integrated Care Strategy that we have developed is actually reducing the harm of alcohol in there as well. So when we look at it, I think I would say, that priority up there for the Integrated Care Partnership is around the work around smoking. This is an area of work that is being led elsewhere, but the Integrated Care Partnership can contribute to that work, and it meets one of the key outcome areas for the Integrated Care Strategy. Does that? Yeah. So the work for this is a much smaller contribution, isn't it? It's not about leadership. It's about contribution. It's about thinking about those pathways and ensuring those referrals are happening into services that are elsewhere commissioned and funded, and thinking about understanding the alcohol level needs for the population, which can then feed into the DASP work. Much more specified.
So, okay, Robin, you've set out exactly what it is you would like to see. Do you need, I mean, is there a sense of, it would be appropriate to ask for some sort of response as to how, you know, we've had an acknowledgement of support of the work you're doing and the importance of it. Would anybody like to respond to particularly what Robin's setting out as a requirement or request? Anybody want to come back on that?
If I could just invite Chris Weiner. Yeah, just because Chris and I have had a conversation about this the other day, and I don't know, Chris, whether you would just want to add any points about.
So, Robin did speak with me the other day about how are we going to engage from a health service perspective in this agenda. It is an important health and well-being agenda, not only for individuals, but as I say, for communities. And my intention is that I will hold the ring on this in terms of the ICB for a period of time. And the organisation at the moment is looking at a more sustainable structure in the medium term. And depending on agreement as we go through that structure, I would expect it to then sit within the medical directorate within the ICB as a key point of leadership within the healthcare community.
Okay, thank you. Very helpful, thank you. Do we have any further comments on this? No, thank you. So, bearing in mind what's just been set out and explained, are we happy to note and support the recommendations to the ICP as on the screen? Yep, okay. Thank you very much, and thank you, Robin. I know this work is very important. I've had briefings from it from Richard Martin, who unfortunately had to leave before we got onto this item. And just anecdotally at the end, I believe this is an area that has got, is reasonably well funded at the moment. It has got...
Yes, so we are currently towards the end of year 2 of the 10-year strategy, and we've had 2 years of increasing funding, and we've had an announcement of the funding we receive next year, which again is increasing. So that will be, it will enable us to put that additional funding into treatment services and to increase that capacity. That's the key importance, that we manage to identify people and to get them referred into those treatment services.
Okay, thank you very much. So from that then, we are happy to receive an update, and so we can add it to our newly created forward plan. Thank you. So moving quickly on then, thank you, and we're now going to have an update on, I suppose, more or less what was discussed last time, the Startwell area of focus from Andy Smith.
Thanks, Chair. This will be a short item. It's a short report for information, really, to provide a brief update on the progress made in taking forward the Startwell element of the ICP strategy, following a more detailed presentation at the last ICP meeting. I should say, yes, I'm Andy Smith. I'm the Strategic Director for People Services. Sorry, I should have said that at the beginning. There were 3 specific requests made when this item came to the meeting in October: to confirm governance and reporting arrangements, to create links to any existing groups and resources that would support delivery, and present the approach to the Health and Wellbeing Board. So where things are currently are summarised at Appendix 2 of the report, and in summary, it's still work very much in progress. So links have been made to approach the Derbyshire Children's Locality Partnership. Startwell has been to the Children, Families and Learners Board in Derby. We've identified a dedicated project lead in the ICBs, but this links back a little bit to the resource issue that came up under the previous item. But that will provide some capacity going forward. and we're planning to take it to the Health and Wellbeing Board in Derby in 2024 and in Derbyshire as well in 2024. So I'd ask the ICP to agree the one recommendation outlined in 2.1.
Thank you very much. It's good to hear that some progress has been made, and also that you've been able to identify a little bit of resource to help that progress on its way. Do we have any comments from anyone else about this update? No. Well, I think we'll consider our forward plan in terms of how we're going to proceed and keep on top of some of these issues. I think we've sort of envisaged we might have a rolling programme of updates, but obviously if that just starts to seem a little bit mechanistic and just something for the sake of it, then we won't do that. But I think we do need to be kept abreast of developments meeting by meeting, but we can review that as we go forward. But thank you very much for that report, Andy. It's really good to hear that there is progress there. Right, now we'll move on to Ellie Holston. I nearly said Houston. Robin Jewis and Chris Viner, who are going to give us the report on the, an update from the Prevention and Health Inequalities Board, which I believe the report came last time on the creation of that board, so it's a very new board.
That's right. So this is really just for information. So you'll recall at the last meeting that the partnership board approved the establishment of the Prevention and Health Inequalities Board, and there has been meetings since then, and the terms of reference are currently being drafted, and they will be brought back to the next Integrated Care Partnership meeting for approval, so they'll be taken to the first meeting, official meeting of the Prevention and Health Inequalities Board for consideration, and then they'll come here after that. And it's also worth noting that on the 28th of November, NHS England published a statement on health inequalities, which has implications for the system, and the board will also consider that and include that in a future date.
Okay, thank you for that, Ellie. So, fairly strategic and high level and early days for that board. Any particular comments? I think I'm not sure when we'd want maybe want something with a bit more detail next time about the activities that are happening. So we have our forward plan, which we can work through about when we're going to bring some of these things back for future meetings. But obviously, hopefully that will be sooner rather than later. Thank you. And I think now we're on to our final item, which you may have heard me mention that we want to create a forward plan. So Alison is going to talk to us about that at the moment. Thanks.
Thank you. Yeah, not a huge amount to say other than, we've got the intention of creating a forward plan. That will include, as you said, kind of the rolling programme around the key areas of focus. I've noted in Appendix 1 kind of an outline or kind of provisional outline and started for 10 in terms of that forward plan. Just to note, Ellie, Robin and Chris, I had penciled in kind of Prevention and Health Inequalities Board coming to the next meeting of the ICP on the 8th of February, but I'll perhaps have a conversation in terms of when that board is happening and put that in as appropriate. And also to note for 8th of February, there is a further item that's been put forward by Linda, who's unfortunately left now, around the development of an emerging approach to joint people and culture work programmes. So I'll add that on. But a reminder to kind of all members of the board, they are welcome to put forward items for the agenda. But also, I think there's a potential opportunity. I think there's a discussion within the kind of system exec meeting around potential items for the Integrated Care Partnership. And I think at the minute we haven't really got a route for those coming through. So there's perhaps thinking about how we more formally kind of link in with that group in terms of putting putting agenda items forward. And I was also just finally going to suggest that we perhaps have a for information item at the end of each meeting, just with that forward plan on, so we can see what's coming up and add to within the meeting as well. I think that's all I wanted to say, Chair, on that.
Yeah, thank you, Alison. Yes, just to reiterate that we obviously have to set an agenda, and we take that as recommended. But having this sort of just this kind of administratively means that it's an open invitation really for anyone, particularly maybe the voluntary services and people who like that, who want to bring something for discussion. Obviously it has to fit in the agenda. We have to have a meaningful report or somebody to provide a meaningful report on those items. But I think especially I feel that now the integrated care strategy has been, you created that last year, and now we're into feeling our way and developing the partnership, which is happening nationally. None of it's set in stone. At least this, we'll see how this works. Again, none of this will be set in stone. It's just, but if you've got a proposal, you can talk to Alison, we can get it on there, we can discuss it. And just very briefly, one other thought I've had, having spoken to various people who are chairs of ICPs elsewhere, is whether, well, I wouldn't recommend that we do this now, but sort of going into maybe next year, we start thinking, well, middle of next year maybe, we start thinking about, we review how many meetings we're having, how frequently, and also consider having ICP assemblies, which I think they have in, it's just an idea, very unworked through at the moment, because I'm aware that they have those in Nottinghamshire, and they are like open days for people who work right across the system to have an opportunity to mix and connect with other people in the system. So sort of not necessarily always just people at the kind of director and exec level, but at other levels in the system. So that's a very general idea. It may not be something we want to do. I know, Richard, you have your days, don't you? And there was to be one tomorrow, and it's been cancelled for tomorrow, hasn't it? So you're going to set another date in the new year. So do you want to? Thank you. Thank you. Do people want to respond to that, or I suppose I get your point. I think there is, for just from my point of view, as you've asked the question, I'm happy for somebody else to give you the answer. Go on, Chris.
I haven't got the answers. Carol, do you want to come in before I give a view?
I didn't see you, Carol.
She's waving at your chair, but
I didn't see you. I've got a blind left side, and no comments on that, Carol.
Yeah, I think, it's all about prevention. The problem with prevention is that a lot of it takes a long while to see improvements, and it's how you monitor that. And we do our best to keep the figures up to date, but it's a major thing to try to gather all the information. And as you say, when you start a project, and even with the smoking, we're doing a lot of work there, and we've got the figures, but they're always a little bit behind. And it is a matter of just trying to collate all the information, because so many people are doing it as well, and it's trying to get all that information. It is difficult, but prevention, whatever we do, you really don't get the proper outcomes. You can see where it's going in the trend, but you don't get the proper outcomes for quite some time. So, yeah, that was just my input on that.
Yeah, thank you. I totally agree, Carol. Thank you. Chris?
Yeah, I was just going to suggest that we're creating a forward plan based on the priority areas, start well, live well, age well. Part of that planning will say what are the outcomes we're looking for, and I agree with Carol, some of the early outcomes will be interventions. Have we taken interventions forward that we think are evidence-based? And then as you get into medium and longer term, you'll start to see the outputs, the actual outputs. So I think it should be part of that planning and show and be able to show the outcomes that we're wanting to see. So you're right, Richard, we do need to get more granular in what we're trying to see, but I think it will come through the forward plan is probably what I'm saying. Thank you.
If I could just strongly endorse that as well. I have spent, I've spoken to Carol quite a few times, and yourself, Richard, and other people, and I've been to this conference, and I've talked to people from the NHS Confederation, and I think in terms of, there's obviously really key health outcomes that the NHS wants to achieve, and public health, and we probably know what a lot of those are. We've talked about some of them today. Some of those are measurable, and some of the prevention measures are measurable, but that's more tenuous, I think. But I think there's a couple of things happening here. There's also this point about what is the integrated care partnership, and so that's not set in stone. We're trying to develop. This is it. We're trying to develop it. I think at the moment we're still at that point, and that's why I dwelt some time on the 11.1 item on what was asked for Escalate, because these are key problems that trying to work as a partnership. So we're just at that point in terms of this body or this entity where we're trying to do that at the beginning. We're at that kind of point. So I agree. The whole point of doing this is not just to have meetings but to have outcomes, and that is the only point of doing it. But at the moment, you have to, in terms of the agenda of working together as a partnership, you have to kind of keep on developing that, and I think that's at the phase we're at now. But there can be simultaneously a focus on outcomes, but everybody's advised me that it will take time, and it is best to engage the sort of wider community of health and social care and voluntary sector, and hopefully education partners in the discussion by perhaps having assemblies and such.
Hi, I'm Kate Brown, Director of Joint Commissioning and Community Development with the ICB. Another reflection, again, really difficult challenge, but I think there's something about how we achieve more together, and how we, as a potential metric of whether we're doing that, is whether we're identifying those enablers and unblocking them. So the data issued, IG data sharing came through, and when I was heavily involved in developing the strategy, lots of people fed back that we knew that what the high-level objectives and outcomes were. There was some sense of shared purpose, although it's been really helpful to consolidate that, and we continue to do that. But there were barriers in the way that we worked either organisationally as silos or between statutory and non-statutory partners. And so the real test is whether we're collectively identifying and removing those. So maybe one way as we're on this journey to improving things is asking people whether it's easier to navigate around the system, either as recipients of care and support, whether as people working in it. It's easier to, if they come across a problem that might be outside of their professional direction, they can quickly understand and navigate to other parts of the system for that wider support. So maybe, and within, very linked into the Ageing Well programme, which we'll be talking about next time, we've been trying to, as well as looking at whether we're making a difference to care and activity, ask professionals whether it's easier to work in the system and whether that some of the team approaches are making that easier. So there's something about learning about how we can do that and share some of those approaches as just an indicator of whether we're making progress, given the challenge of the longer term, the long timescales it can take to play through into actual outcomes for care. So just another thought in terms of a focus on enablers and what staff and our population are telling us whether it's feeling more joined up in how we work.
Yeah, thank you. Some really key objectives in there. I'll let you come back in a minute, Richard, because I'm just going to, I'll let Kim come in. Absolutely. And I think that's really at the stage where we're at, and it will take time. And we have limited resource. So those are all key factors. Thank you. Kim.
Thank you. I completely agree with what Kate's just said, actually. And I think there's also that picture for me where actually we've talked for a long time about prevention, but actually the gap has got wider. And, if you're healthier, you'll be healthier if you're wealthier. We need as a system to really start looking at this across the piece. So for me, the whole workforce piece, how we build and work with communities, support resilience in communities, integrate communities, where we know there are health inequalities, will make a huge difference and impact. So, and we have to be able to measure that, and we have to work within our priorities. But for me, the fundamental shift in the system, working more with communities and again, bringing them along and making sure they understand the system will be vital in terms of how we measure that prevention from my perspective.
Thank you, Kim. And I think it is vital we bring people in. Do you want to come back now, Richard, or do you want to follow another comment?
I just wanted to make the point. I understand this is long term, and I totally accept that. I mean, everything else. But I think there are things we can measure along the way. For instance, are we accessing all the different groups in society? The equalities things is the things we do in actually getting to the different groups, because that will be a really good indicator that actually if the outcomes do come from the work we're doing, then it will be shared across, but we need to know we're doing that early. I'm just going on things like that actually to show that what we're doing is getting to where we need. That's what I'm, as well as producing the outcomes that we need. There's a number of things that I think we should be testing ourselves at all the time. Thank you. Thank
you, Richard. Yes, absolutely. So I've got a chap at the back and then yourself to draw the meeting to a close, which is probably what...
So Chris Pienaar, Derbyshire, representative VCSE. So just following all of these comments actually is just also not just in Derbyshire but internationally, in terms of silo systems, the barriers, one of the barriers, the key barriers is that a lot of preventative work can't take place because where the outcome gets attributed is not the same budget. Okay, it's as simple as that. And so therefore it often doesn't happen or can't be funded. So this is a great opportunity that we have now with the integrated care strategy and the joined up working. So I think that's also something to look at in terms of impact, is are we now able to release a lot more preventative action because it is systematic and it can be attributed in the right places and can be spent. Thanks.
Indeed, thank you very much for that. And then...
Hi, thank you, Chair. Belle Hobbs from UHDB. I wanted to reflect on your original comment around how are we measuring the impact, because I think representing the sharp end of that, it's a really interesting question, and I think the opportunity as a care system is so vast, and I think we are the reactive end of that. And I really welcome, and I would really like to endorse the sort of the comment around how are we measuring the impact of prevention and the impact that has on ultimately on our acute services. And I think the gentleman's point of breaking down the barriers of silo working, again, I would just like to say I really welcome and endorse that from a provider perspective.
Okay, thank you very much for that. All right, well, that's some very, unless anybody else wants to make a comment around that item, so that That was a very interesting forward plan discussion. Thank you very much for those comments. That's really helpful. I think there's a vast amount of work to do, and the objectives are huge and ambitious, and resource is tight, and people's energies are taken up. But I think hopefully we will be able to achieve some of the objectives set out in the integrated care, that you set out in the integrated care strategy, by continuing to work together. So you're aware that we now have the forward plan, and so I hope you will contribute to that, and we will have to look, Richard, as you say, considering a stronger focus on outcomes in the reports. Maybe we could add that as a section in the report. That's something we could do. But in the meantime, thank you very much for attending this afternoon. It's a really interesting session. Thank you for all your time and all your work, and have a nice Christmas, and hopefully I'll see you in February. Thank you.